Pancreatic cancer. Etiology, pathophysiology, and pathology. Most primary malignant tumors of the pancreas are adenocarcinoma. Risk factors include increasing age, male sex, smoking, alcohol, chronic pancreatitis, diabetes, within 2 years of diagnosis of type 2 diabetes mellitus, and hereditary pancreatitis. Epidemiology. Pancreatic carcinoma is the fourth commonest gastrointestinal tumor. Its incidence is increasing in the Western world, in the range of 5-10 per 100,000. Male to female ratio is 1.3:1. It is rare in patients under 45 years old. Clinical presentation. Common. Painless cholestatic jaundice associated with varying degrees of pruritus, pale stools, and dark urine due to common bile duct obstruction. Weight loss. Abdominal pain. Uncommon. Vomiting, from duodenal obstruction. Malignant ascites. Unexplained exocrine pancreatic insufficiency. Unexplained episode of acute pancreatitis. Rare. Venous thrombosis, thrombophlebitis migrans. Diabetes. Physical signs. Common. Jaundice and cachexia. Uncommon. Palpable gallbladder, Courvoisier's sign. Palpable mass. Ascites. Investigation and staging. Blood tests. Routine blood tests show nonspecific changes related to biliary obstruction. The pancreaticobiliary tumor marker CA19-9 may be elevated but is not specific to pancreatic tumors. Non-invasive imaging. Abdominal ultrasound may show a dilated biliary tree. A pancreatic mass may be demonstrated, but the absence of a mass on ultrasound does not exclude a pancreatic malignancy. Dilatation of both the common bile duct and the pancreatic duct is highly suggestive of a carcinoma of the pancreatic head, double duct sign. NB. The absence of gallstones on ultrasound in a patient presenting with acute cholestasis and a dilated biliary tree suggests the presence of a common bile duct strictures due to a carcinoma of the pancreas or cholangiocarcinoma. Abdominal CT or MRI CT. Scanning is useful for demonstrating the mass and for staging, i.e. demonstration of invasion into important local structures or evidence of distant metastases, Fig 37. Invasive imaging. Endoscopic retrograde cholangiopancreatography, ERCP, duodenoscopy allows assessment of the ampulla of Fata and identification and biopsy of a lesion if present. ERCP allows diagnosis and placement of an endobiliary stent to allow relief from biliary obstruction in patients, the majority, who are unsuitable for surgical resection. Carries a significant morbidity and mortality. Percutaneous transhepatic cholangiography, PTC. For cases where ERCP has failed or is not possible, e.g. previous surgery such as polyogastrectomy or Roux-en-Y biliary reconstruction, also allows placement of an endobiliary stent. Endoscopic ultrasound, EUS. CT and transabdominal ultrasound can miss lesions less than 2 cm in size. EUS is particularly good at detecting these and has the capability of directing tissue sampling by either fine needle aspiration or biopsy. The fact that it has higher resolution than other imaging modalities allows clearer definition of local invasion into vascular structures and therefore resectability. CT-guided biopsy. Useful in selected cases where the diagnosis remains obscure and where surgical resection might be considered if a positive diagnosis of adenocarcinoma is confirmed, but there is a risk of seeding along the track. NB. Pancreatic tumors are very fibrotic and biopsy has a higher sensitivity than aspiration cytology. Differential diagnosis of acute cholestasis, cholelithiasis, intrahepatic cholestasis, e.g. drug reaction. Of pancreatic mass, ampullary carcinoma, tumor arising from the ampulla of Fata, which has a better prognosis. Treatment. This depends on suitability for surgery. Patients who have resectable disease and who will be operated on in a timely fashion may not require stenting. Routine preoperative biliary decompression has not been shown to be beneficial. Short term. Those with extremely symptomatic jaundice may require stenting prior to surgery, but the route of delivery and type of stent is controversial. The British Society of Gastroenterology guidelines suggest plastic stenting via ERCP, although many centers prefer metal stenting via PTC as there is a lower risk of pancreatitis and therefore less risk of unnecessary delay. Long-term or according to stage. Curative surgery. In about 20% of patients, pancreaticoduodenectomy, Whipple's procedure, offers the possibility of a surgical cure. No other form of therapy is associated with long-term survival. Palliative surgery. Surgery may still be beneficial in patients with advanced disease by providing combined biliary and gastroduodenal bypass. Can be performed laparoscopic in some cases in some centers. Chemotherapy and radiotherapy. Oncological therapies in pancreatic carcinoma are used to help control symptoms and improve quality of life. Multimodal therapy, external beam irradiation combined with 5-fluorouracil chemotherapy, has been shown to have no advantage over chemotherapy alone, providing minimal survival advantage, in the range of weeks. In recent studies, gemcitabine, a pyrimidine nucleoside analog, has been shown to improve quality of life, and there appears to be a modest but significant increase in response rate and survival using regimens containing this agent. Palliative measures. Relief of jaundice and pain control are the main objectives in patients with advanced disease, and many require opiate analgesia. Anorexia and weight loss remain major problems. Nutritional issues. The addition of pancreatic enzyme supplements, such as Creon, has been shown to improve quality of life and reduce cachexia in patients with advanced pancreatic cancer. Prognosis. Morbidity. Most patients with pancreatic cancer have incurable disease at presentation and will experience pain in addition to progressive anorexia and weight loss. Mortality. Of individuals presenting with carcinoma of the pancreas, 90% are dead within 1 year.